time we saw several days in a row in the high 700s was in May. So as we've said several times in recent days, we have unfortunately returned to the level of cases that we were seeing later this spring. However, important to note that we are testing much more rigorously and much more broadly than we were in those late spring days, and that will be a focus of our call today. The median age of our cases remains at 36.0 years old. That is unchanged from a week ago, but really notable again that we have that 36.0 year old median age today is down from a high of at least 43 years old of median age back in the earlier days of the pandemic. So the shift in age range among our cases has been truly notable. Sadly, we had 6 additional deaths among Minnesota residents reported yesterday. 3 of these deaths were in Hennepin County, 1 each in Olmsted, Ramsey, and Scott counties. This total includes 1 person in their late 20s who did have underlying health conditions, 1 person in their 70s, 2 in their 80s, and 2 in their 90s. There are 312 patients currently hospitalized. 151 of them are in intensive care. This represents a net increase of 14 people in the hospital from the day prior, 10 additional in the ICU. And again, these are levels of hospitalization that we've not seen since May as well. So today we want to talk about testing and a few other issues. I'll just give a couple more updates on testing statistics. Yesterday's laboratory volume was 16,660 lab tests processed yesterday, or from which we received results yesterday. And that means that our testing volume week over week, we saw an 11.2% increase in total tests over the past week, compared to a 10.1% increases in new positive cases since last week. So we see those numbers getting a bit closer together. The 7-day rolling average testing positivity rate is 4.9%. So it's been at that level for the last couple of days and has ticked up slightly in the recent couple of weeks. Before turning further into testing, a couple of additional updates. One related to data that you find on our website. We've continued to make updates and improvements and additions to the data that is publicly available each day on our website. In addition to the daily situation report, we do post an updated weekly report every Thursday. So yesterday we made some additions and improvements to that weekly posting. We added a slide showing the weekly percent of tests positive at the county level and showing that over several weeks. So people can see how test positivity, which we keep stressing is a really critical number, how that plays out at the county level and how that's changing over time. We also added a slide about childcare related cases. It shows how many cases there have been in staff and attendees in these programs, as well as how many total programs have had confirmed cases. And as we've mentioned on these calls before, the majority of confirmed cases in child care settings have not been due to transmission at the child care center or program. And of the centers that have had cases, 70% of them have had only 1 confirmed case. And Chris can comment further on child care related questions if you have them. We also added a slide on statewide testing and positivity rate data by week. So again, at the state level, in addition to the county level data I talked about before. And this does show how the average positivity rate has changed over time, as well as how many actual tests were being done each week. So quite a bit of visibility and granularity there to how the testing kind of backdrop has continued to change in our state. One thing that we added on the daily situation update page is the total number of people tested. And as reporters may remember, we have over time changed what it is we're counting. Early in the pandemic, we were counting total number of people tested. Then we've shifted to showing with our testing data all the tests that have been done, because we know that many people are being tested multiple times, which is the recommended protocol, for instance, in long-term care, as we've discussed. So it's important to really have both of those metrics, total tests done and total people. So that's just an additional cumulative data point that we're trying to be clear about. I do have some news to share that we want people to be aware of. We know, we got some confirmation yesterday that a person who attended the North Country Rodeo near Effie, Minnesota, which is in Itasca County, and that rodeo was run between July 25th and 27th. We know that one person who attended that rodeo has tested positive for COVID-19 following the event, and it was determined through the case investigation that the person was infectious while at the event. So we know that there were many, many people at this event, so there's certainly a possibility of other exposures. And we don't know how many. We're still doing the follow-up investigation, but we just want to get the word out right now, given the number of people at that event, that we want to just encourage anyone who is at that North Country Rodeo event to just be vigilant, watch for symptoms, get tested if you do develop symptoms. And you should really consider, strongly consider, and we would urge you to limit public activities as much as possible for the next 14 days. Really, keeping in mind the importance always for all of us to practice social distancing, but particularly when you know that you have participated in an event that has known case exposures associated with it. So very important for everyone to practice social distancing. And please do wear a mask if you do need to be around other people to help prevent further spread. As we know, as we keep saying, so many people who don't have symptoms can still spread COVID-19 if they have been exposed and actually contracted the virus. Now, I want to turn to the important milestone, testing milestone that we actually crossed yesterday. This week, we hit 1 million total tests having been completed in Minnesota. The infrastructure that we've built has allowed us to build our testing capacity in a very significant way, and it's been made possible through key partnerships between the State Health Department, our State Emergency Operations Center, and of course, our unique private testing partnership with the Mayo Clinic, the University of Minnesota, and the leading healthcare systems all across our state. Working together in a seamless laboratory system and strategy, we're aiming to make sure that anyone that needs to be tested can get tested. Testing for COVID-19 has certainly not been without its challenges from the beginning of the pandemic through today. And we continue to address issues that arise as more and more testing is needed here and across the country, especially with the really explosively rising case numbers we've seen in some regions of the country. That has just driven up testing demand to a very significant degree and has once again led to shortages of testing supplies, which can impact how quickly people get their test results. And it also has really made it necessary for some clinics and hospitals to prioritize people more narrowly for testing when their supplies are limited. The longer wait times to get test results certainly can be frustrating for people, and we certainly understand that. But it is so very important that people stay home while you're waiting for test results, especially if you have symptoms. That's one way that you can really do your part to help prevent further spread. And we don't want to discourage people from getting tested if they're recommended to get tested. So this conversation we've been having about the fact that, yes, indeed, supply chain challenges have reemerged, testing turnaround times are getting longer. None of that is intended to discourage people from getting tested. We want people to get tested if they have been recommended to get tested, if they're symptomatic, if their provider wants them tested, if you hear from public health that you may have been exposed and are recommended to get tested. So please do still do what you're doing as Minnesotans to seek out testing if that has been recommended for you. We still recommend testing for all people who are symptomatic as a top priority for our providers to help test as soon as possible. There are also recommendations for times when people who do not have symptoms should get tested, as I mentioned. These include people needing certain medical procedures, people who are linked to a potential source of exposure to an ongoing public health investigation, and people who were known to have been exposed to a person known to have COVID-19. And in these situations, either your provider, your healthcare provider, or a public health worker will be in contact with you to let you know that you should get tested. Testing is such an important piece of the puzzle in our statewide response to COVID-19, because it's through testing that we can identify cases and provide people with the information they need to help take care of themselves and to help prevent the spread of disease to others. These steps, along with the critical everyday actions we keep stressing, like keeping social distance, avoiding close contact in large crowds for extended periods of time, wearing a mask, washing your hands, and staying home when sick are what we all need to do. I know how weary you are of hearing me say those things day after day after day, but we just can't stress enough, no matter how basic these messages seem, how important they are in protecting our communities and how much power we actually have in our own hands as Minnesotans to really help control the spread of this virus and to make it as possible as we can to continue to return to the activities, certainly in new ways with some new practices, but to have our businesses open, our schools, and the like. And now I appreciate that we have some guests with us today, and I'd like to begin by turning it over again to Dr. Bill Maurice, who is chair of Mayo Clinic's Department of Laboratory Medicine and Pathology and president of Mayo Clinic Laboratories. Dr. Maurice, thanks for joining us.
Oh, thank you, Commissioner Malcolm. It really is an honor for me to be joining you once again to discuss, the COVID testing for Minnesotans. And I just want to say that at Mayo, we're just extremely we have a deep sense of gratitude that we're able to take our call to help the country and the state with its COVID testing needs, and to partner with the university and with you and the Department of Health and the other health systems in the state to make that testing available. To date, at Mayo alone, we've run over 424,000 tests, COVID diagnostic tests for Minnesotans. And so that's, again, empowered through the partnership and shows the power of that partnership. We also recognize, though, that this fight is far from over, and we're really committed, particularly as we get to the end of the summer and in the fall, to work in the communities that we are in and across the state to get the testing out there that people and Minnesotans need to really manage this pandemic. And continue to work with the state and the federal government to get testing to the people and the areas where it's really needed, because I know that's a continued concern for all of us. As you mentioned, to do that is really, it continues to be a challenge. We have had people working in the labs essentially around the clock, continuing to bring in new platforms to do the COVID PCR testing, the diagnostic testing. Just because of the supply chain challenges means that we have to be working with multiple companies and multiple platforms to ensure that that testing is available. And we continue to ramp up and increase our testing capacity actively here to meet the needs of Minnesota and the country at large as well. In addition to that, we have really been focused on, as the university has as well, I'm sure we'll hear from my colleague, Dr. Shacker, continuing to try and innovate in terms of how we move the testing around the state to make sure that we have the IT infrastructure to get not only to get the tests done, but to get the results back to individuals as quickly as possible, because as you know, that's also extremely important for each person getting tested. Also, with the university, getting the blood testing, the serologic testing available, so we can understand who in our communities has had the virus and has recovered and has at least mounted an immune response. And also, we've worked to develop new tests like the neutralizing antibody test, which is another blood test that not only tests for the antibodies, but how effective it can be in actually combating the virus itself. And that'll be really helpful, I think, as we look to do things like build a convalescent plasma treatment program where we take blood from individuals who have recovered, and if they have these antibodies, it can be used to help those who have either been exposed to SARS-CoV-2 or are suffering from COVID-19. So those are all things that we will continue to work on in collaboration with the university and other health systems across the state to grow. And to your point, we just really want to be sure that every Minnesotan that needs a test can get access to a test. That is going to continue to be a challenge just because really the entire globe is challenged for having enough COVID testing available to manage the pandemic. And so we feel that here in Minnesota, but we'll continue to work to make the tests available and help guide, work with the state health systems and with the physicians and providers to understand where the test can be used to maximal effect so that it's available, because I think thoughtful and rational use of the tools that we have with a real purpose will enable us to do all the things that we want to do and need to do as a state, including reopening the schools safely for educators and students and preventing the spread into homes. So the last point is, because those resources will continue to be stressed, I just want to echo your thoughts that we have to continue to be vigilant. As tiring as that might be, everything that we can do to prevent the spread or the need for testing through social distancing, through mask wearing, it really not only helps you, but helps your fellow Minnesotans. And so we all really need to embrace that to make sure the people that really need the testing and other tools to combat this disease are available to them. So pleased personally to be able to work with Dr. Shacker and you and others to bring this, to get to this milestone, and just you'll have our continued commitment to do whatever we can do to help the state in managing the crisis. And so I give it back to you, Commissioner Malcolm.
Thanks very much, Dr. Maurice. It's really encouraging to hear about the continued innovation and being on the front edge of developing new tests. I appreciate your comments very much about the need for smart testing strategy to make sure that we're setting our priorities and using the testing resources to the best effect we can, just given the reality of the supply chain challenges, which are just going to be with us for a while. And I know you are doing as much as you can to work with us and with everyone on the supply challenges themselves, which is something else I know our other partner at the University of Minnesota is also working on. So I'd like to introduce again Dr. Tim Shacker, who is Vice Dean of Research at the University of Minnesota Medical School. Dr. Shacker.
Commissioner Malcolm, thank you. And I'd like to just echo and reinforce what Dr. Maurice has said about the importance of testing and vigilance. At the university right now, today, we're running approximately 6,000 tests per day. And our turnaround time is averaging in the 24 to 48 hour range. That's at present, and that's like everything else dependent on supplies and that sort of thing. One of the unique things about our operation is that at the very beginning of the pandemic, we recognized the need to be as independent as possible. And so wherever we can, we do what we call homegrown tests. These are tests that are designed by the scientists in our laboratories that are clinically validated and don't rely as much on supply chain issues. And one of the, I think just recently we've seen one of the advantages of that. As Dr. Maurice said, we're in very close collaboration. Our laboratories are talking to each other every day, and we're balancing where the tests go depending on what the capacity is, where the tests physically are, and that sort of thing. So because we have this homegrown test, the homegrown PCR, that has been less sensitive to supply chain issues, and that's been helpful as testing capacity needs increase. The other thing, just extending, beyond that, talking about the scientists at the university and the capacity that we have. As the need grows, we're looking at different ways of expanding our capacity. Ours is a collaboration between the University of Minnesota Genomics Center, Lab Medicine Pathology, the Advanced Research Diagnostic Laboratory, our clinical partner with Fairview. So there's a lot of folks that are working hard to think about how can we expand our capacity and how can we make sure that we meet the needs of the people of the state of Minnesota. One of the examples of that is at the University of Minnesota Veterinary School, we have a reference lab that basically does for mostly farm animals, but the kind of testing that we're doing for humans. And so they have capacity. We've been working with them to bring capacity up for doing more COVID sampling, COVID-19 testing. So as our testing, if we have an overflow and need to bring on more testing in a given day, then we can just go to the vet lab, and they're already operating and doing testing for us. So I want to reiterate that the University of Minnesota is committed to working with you and the Mayo Clinic to bring as much help as we can to fight this pandemic on behalf of the people of Minnesota. And I have to reinforce what Bill said, Dr. Maurice said, we are far from out of the woods. I keep pointing out to people that it was little more than 6 months ago that the sequence of this virus was first published. And in those 6 months, we have created diagnostic testing. We have created new innovative therapies because of what we know about this virus. And these clinical trials are being done today at the University of Minnesota, at Mayo Clinic, and other places. And we have made significant changes in the way that we treat our patients, and this has made a significant improvement in patient outcomes. And this is all in 6 months. You know, there are 3 or more large clinical trials all over across the globe with vaccines that currently show great promise. And so just in 6 months, these vaccines are already in phase 3 clinical trials. So while there's a long ways to go, everybody needs to be vigilant. And I think we can be optimistic that that therapies are improving. There's a vaccine that we hope on the horizon, but now is not the time to let down our guard. So with that, I'll give it back to you, Commissioner Malcolm. Thank you.
Well, thanks, Dr. Shacker. I really appreciate you reminding us, because we talk a lot about COVID time, and how much has happened in 6 months is really important to remember. And the pace of innovation and the pace of collaboration that's happening, certainly in Minnesota. We think that's one of our strengths with this partnership, but it is gratifying to see the way that scientists around the country and around the world are really pulling together. And you are quite right to remind us of how far we've come in the short 6 months. Now, I would like to introduce you to Brendan Barrow, who is, as I understand it, Brendan, you're a Minnesota college grad who recently came back to Minnesota after having been in Seattle, Washington for a while. Apparently you showed some symptoms of COVID and were told to get tested. So we really appreciate your willingness to share your personal story with us here. So over to you.
Thank you so much for having me. Yes, as you said, I was recently living in Seattle, Washington for the summer, but I decided to come back here to care for my family before I go back to school in the fall. And, my biggest concern, my big reason for getting tested is, in Seattle, I was working in a warehouse, and I had started to show symptoms. And although we took precautions, I really wanted to be sure that my family was safe, that I was not bringing COVID with me. So I quarantined when I got back. I lived by myself, and the process of scheduling a test was incredibly easy. I just had to go online. I found a place that I ended up going to Alina Health in Hastings. It was a little bit of a drive, but I love a good road trip as much as the next person. And, for me, the testing process was easy, and it was really worth it because, I think the biggest thing is one of the reasons I came back was my grandmother just got out of surgery, and, she's in her late 70s, and for me to just go and hang out with her without getting tested, could be really dangerous. And, I miss my grandma, and, and I knew that, and I talked with my family, and, if I really wanted to be able to hug her and, tell her I was thinking of her and caring about her, that, that having that negative test would be really important, you know, so that I knew that she was safe, especially since I was, you know, showing some pretty significant symptoms. But the good news is I was able to get in and get tested on Monday. I heard back within just a little bit over 48 hours, and I got tested negative. I've already made plans to go see her tomorrow. My symptoms have subsided, so that part is great. But the testing process itself, I can't speak highly enough of my experience with the line of health. I think people have stories of, oh, getting a thing stuck in your nose, but they've made it so streamlined. It was so easy. And I think, you know, I'd heard things that were not great, and they were all false. It was super easy, took 2 seconds. Everyone was super friendly. And, you know, I highly encourage that if anyone's worried about getting tested, I felt very safe. The process was super easy, and, you know, it was a really good experience. And hearing you guys talk about all the work you've put in to keep Minnesota safe, it's just amazing to hear. And I just want to thank you all so much for your hard work. You know, I get to hug my grandma tomorrow, partly because of the work you guys are doing. And that means a lot to me. And with that, I will toss it back to Commissioner Malcolm. Thanks so much for having me today.
Well, thank you, Brandon, for sharing this story. We're glad that you had a good experience, and we certainly know that folks are working hard to find the testing they need, and we know it's not always just as seamless as what you reported, but we know that from what we can tell, with the feedback we get, that the majority of the time it is working well, and we need it to. So I'm really, really glad to hear that you had a good experience, and thanks for sharing your story with us, Brendan. With that, I appreciate that we had a lot of guests with us today, but really wanted to not only note this very important 1 million test milestone that we've passed this week, but to give you a little bit more insight into kind of some of the scientific work that is ongoing behind that. So with that, Mike, I'll turn it back to you for opening up the Q&A.
Thank you, Commissioner. Operator, I think we're ready to take questions.
Thank you, ladies and gentlemen. If you wish to ask a question at this time, please press star then one on your touch-tone telephone. If your question has been answered or you wish to remove yourself from the queue, please press the pound key. To prevent any background noise, we ask that you please place your line on mute once your question has been stated. Our first question is going to come from the line of Jeremy Olson with the Star Tribune. Sir, please go ahead.
Commissioner, this isn't my question, but I wanted to fact check something you said. Did you say the person was infected at the rodeo or was infectious while attending the rodeo?
Yes, thanks, Jeremy. I appreciate you asking so that we're clear about this. They were infectious while at the rodeo.
Okay, thank you. And then my question's related. The new school guidance yesterday really threw public attention onto county case rates and how some counties, especially rural counties, have some really elevated rates. It made me wonder if a lot of counties are having spikes due to single events like potentially this rodeo or other events. How much of this is due to a single event where the virus spread widely from there?
Thanks, Jeremy, and it's a really good question, and it goes to underscore kind of a really key point about this safe school, safe learning plan. The county case rates are the starting point, and we keep emphasizing that, and you do need to look below the level of the county data to understand what might be driving it. Your point's exactly right on. In some counties, we know there are specific outbreaks going on that are associated with a known event or a known setting. Sometimes it's because we're doing widespread community testing in response to an event. So all those local factors are why we keep saying it isn't just the county case rate that's the issue. It's the trends. It's more granular data that we have at a local, a more localized level. We can and do, break things down to the zip code level when we need to. So particularly with some of these, large geographic counties with relatively low populations, that rate is a starting point, but you really do need to dig in to the specifics, and particularly to understand how much risk there may or may not be for an individual school. So thank you for asking.
I guess my follow-up would be, while we do seem to be able to trace a lot of events or a lot of outbreaks or cases to specific events, we're now at an all-time high for the state of a 35% rate of community transition being unknown. Is there any new information on why our rate is increasing so much on that metric?
Another great question, and you're completely right. That's why community spread of unknown origin is one of our dial-back measures and one of the things that we've been expressing some alarm about in recent weeks. We do think that that's because of the degree to which folks are just interacting more. We know that there's just a lot more social interaction happening after the middle of June, when some of the reopening guidance, capacity limits, gathering size limits were all relaxed. And we've talked a lot about what's going on with large parties, with celebrations, with certain venues like bars, for example. And we think that people are actually, and the case reports indicate some people are participating in a number of different events, making it hard to know for sure what was the initial source of exposure. But we think it's that general kind of level of community interaction and the amount of gatherings that are happening in larger crowds in closer quarters than the guidelines or the current executive orders really set out the parameters that, as Chris Ayresman has said many a time, and I'll turn it over to Chris in a sec here to see if she has anything to add, that from our case investigation, it's just pretty clear that the current executive orders aren't being adhered to as well as we need them to be, which is why we keep reinforcing that we're still talking about limiting size gatherings and close quarters and still needing people to keep social distancing, and the new mask mandate is so very important. So that's a long answer already, but Chris, I don't know if you have anything to add.
Thank you, Commissioner. I will just comment that, as we see cases associated with a particular event, and then those cases, they get additional cases, and it's that ripple effect that gets you to the point where you're seeing cases in the community that don't have a direct link, and that's what we're concerned about. We're concerned about the individual case and the individual event, but we're also concerned about how that event then, as a stone in a lake, kind of has a ripple effect going out. We are concerned about that ripple effect, and what you're describing is the effect of that continued case spread from individual events.
Thank you.
Thank you. And our next question comes from the line of Emily Havoc with CARE 11. Your line is open. Please go ahead.
Hi, thanks for taking my question. Large public gatherings over 250 people are completely closed right now, is my understanding. How did a rodeo that large happen? And was MDH aware of it ahead of time? Was the county, asked not to hold it? I'm just wondering how that many people were getting together up there.
Chris, could you take that one?
Sure. The individuals who were organizing the event had reached out at different times to various state agencies to get guidance and information. And so we had provided information about the limits of size. And then the organizers made a decision. They reached a point of frustration, I think, with what the executive order meant for them. And they reached a point at which they decided that they would hold the event and not have guests, but not stop people from participating in a public assembly if they wanted to join in at the grounds where the rodeo is being held. So it's sort of a little bit of a roundabout way. There had been some conversations, but what actually happened apart from any conversations or guidance with how large gatherings should be held.
So is the state, if you guys are aware of something that large that people just decide to go ahead and do, is there any action taken to try to stop the gathering?
We certainly, collectively, various agencies were working with the organizers to try and find a way to have the best possible outcome when they chose to do something different than the Attorney General's office has gotten involved, and you may want to reach out to them. I think they have just recently put some information out related to this. And so they have had a role as well.
And then I know we're going to get some questions, and I've already heard a question about, you know, we had large protests outdoors and didn't see a high rate of cases from that. Do you foresee this situation being different? Was there a big difference in social distancing or precautions between the two situations?
Chris, could you take that as well?
Sure. Yep. Yeah, I mean, we were very grateful for what we didn't see following the mass gatherings in late May and early June. In this particular situation, we're very aware that there was no social distancing and that people were not wearing masks. And while not everyone who was involved in mass gatherings in late May and early June wore masks, we know that a number of people did. So it remains to be seen how we'll see transmission play out with this event. But as we indicated, we're now aware of an individual who attended who was infectious while they were there. And so that does give us pause, and we will be continuing to monitor the situation.
Thank you, Chris.
Thank you. And our next question comes from the line of Catherine Rickett with Minnesota Public Radio. Your line is open. Please go ahead.
Yeah, I was hoping you could first talk a little bit more about the saliva test Governor Walz mentioned yesterday for teachers in schools. When will that be available? Who can get them? That sort of thing.
Sure, Catherine, this is Jan. Yes, we've been working for some number of weeks with Rutgers University and a company called Vault, that they've developed this saliva testing technology. And we know, as with all the reasons we've been talking about, that our current testing capacity, while I think we're doing a good job of being able to surge testing into certain hotspots, we know that testing capacity is not sufficient to meet the growing demand for, and especially for something like, you know, the reopening of schools, where the commitment has been made to make sure that we can test educators, we can test school settings when that's needed. So the idea for this on-demand saliva testing gives Minnesota access to some laboratory capacity in New Jersey, which is where Rutgers involved are, thereby relieving our Minnesota health systems of some of that demand. This is an easy kind of a test. People collect their own samples at home by simply spitting into a sterile tube and mailing it to a lab for processing. And what the governor's announcement yesterday was that all educators and staff will receive access to a saliva test at no cost, and they need to enter their insurance or indicate if they're uninsured, and the state will handle backstop any costs that aren't covered by insurance. Educators will take this particular test in their own homes. With this particular technology comes a telehealth Zoom visit, so that the accuracy of the sample, if you will, has got some oversight to it, which again just is an at-home option, convenient way for educators to be able to submit a sample without going to the doctor's office or a hospital or a testing site. It also reduces the use of PPE, lessens contact with others in the clinic setting. This is an FDA authorized test, which we're watching with interest and staying on top of all kinds of new testing methodologies coming down the pipe, because those will all be important, as the physicians on the call mentioned today, about the need to keep on innovating and having new types of tests available. So this is one particular strategy that we've been examining, and are happy to be able to make this particular saliva test available to educators, as the governor announced yesterday.
I'm sorry, I just want to clarify something you said. You said they would have to mail it somewhere or not? I apologize.
Yeah.
That.
Yeah, this
they
particular test. Correct. Yeah, and when you get a voucher for a test, you order the test. It gets shipped to you. You do you produce the sample again with this telehealth visit, and then you drop it in overnight mail service, and their turnaround time is typically 24 to 48 hours. So we've been doing some some testing just on the process here in Minnesota to verify how easy it is. So it's been proving to be quite good.
So sticking on schools for a second, there was a study that was published in JAMA Pediatrics in the last day or so that shows that viral load among young children is as high, if not higher, than adults. And I'm wondering if maybe Chris could speak to that, or Commissioner Malcolm. I mean, that sort of undermines our entire premise for understanding that schools might be safer because kids don't transmit this virus as much.
Yeah, I think this is Jan. I think it just goes to underscore a point we keep on making that evidence continues to mount. But I'll turn it to Chris on this particular study. Any distinctions between viral load itself and transmissibility might be a slightly different thing. Chris?
Sure. Yeah, what I was going to say is that's important information, and we have been and will continue to be monitoring what we are seeing, on the ground here in Minnesota. And I think, what we can say so far is that what we've seen in these settings is, as the commissioner stated earlier, is that we're seeing more cases in the adults in the settings, and that many of those cases are acquired outside of the child care setting, so that we're not seeing the child care setting as sort of the epicenter, if you will, of transmission. We've really seen, more situations in which there's a case identified, but it is identified likely with the source outside of the center. And as the commissioner said, 70% of child care programs that have had cases have had only one case, and 25% have had just 2 to 4 cases. So what that encourages us with is the fact that we aren't seeing as much transmission happening. So certainly viral load is important, and certainly infectiousness is important, but I think that we've been fortunate that we have not seen a lot of transmission, within our child care settings. And in fact, when you look at the number of children who have been served by these settings, and we look at the number of cases we've seen, and this is estimates because we don't have the exact numbers, but what we find is that it's 0.14% of kids and 1.2% of staff in these programs have had lab confirmed COVID. So we find that encouraging. But to the points that were made yesterday, and just want to emphasize our ongoing commitment to making sure that we have a safe environment. So we're going to continue to monitor this. And certainly if we start to see changes, we will evolve our recommendations based on that.
Okay, thank you.
Thank you. And our next question comes from the line of Bill Werner with Minnesota News NETW. Your line is open. Please go ahead.
Thank you. Say, Commissioner, it sounds, I want to follow up on my colleague's previous question about the rodeo. Sounds like you folks, various state departments were in conversation with these people and they decided to go ahead with it anyway. Would you have had the option to go to a judge and ask for a temporary restraining order? And if so, why was that not done?
I'm going to ask Chris if she maybe has any more particular comments. I think I'm going to defer a little bit on too many of the specifics of the case. I understand your point about, are we doing everything we can to prevent some of these events from happening at all. But I think there are really quite a number of jurisdictional questions and enforcement tool questions that I'm just not able to address in full right now. But I don't know, Chris, if there's anything more you can add.
No, I will actually defer to the Attorney General's office on that. They are the enforcement arm of the executive orders, and so I would defer to them.
Well, let me ask. I understand your position on this, but from the standpoint of the citizens, let me ask you this. The Attorney General's action is after the fact, obviously, because the rodeo went on and there was an infectious person there, and we don't know where this is spread to. That we'll find out, I would assume, at some point maybe. But for the future, what can you tell Minnesota citizens if you're aware of a potential situation like that? Does the state have the power to shut that down in some way, shape, or form, or has that not been defined? And if not, are you going to work toward that as a means of protecting the population against these kinds of things in the future?
Yeah, this is Jan. I'll just say, I think absolutely the executive orders are clear on the fact that these requirements have the force of law, and it spells out what the enforcement authority is, both through the order itself and through the Attorney General's office's ability to bring other action. But certainly we continue to learn from all of these experiences, and to the extent we need to have additional conversations about prospective enforcement actions, we will certainly be kind of reviewing and learning from that. But I really, again, can't say too much more about the specifics of this one case.
I appreciate it, Commissioner, if you could keep us informed if you have discussions and develop some sort of protocols, legal protocols, as it were, on those kind of cases, because I assume we might have more of them. On a related note, the situation with bars, and you know what's happening in Minneapolis on Saturday in terms of bar restrictions. Are you considering dialing that back at all, given what's happening in terms of outbreaks at bars across Minnesota?
Good question, Bill, and certainly we applaud the mayor's actions in Minneapolis. As we've talked about on other matters, we think it's an important principle in the executive orders and in public health practice generally, that we support local jurisdictions being able to do more than any floor that might be established by statewide action. So the fact that the mayor took this action on the basis of specific Minneapolis experience, we think is a good thing. We do continue to look at the numbers, to quantify what we know about cases coming from bar situations, and continue to study what can be known and learned from other states that have taken various restrictive actions, whether they can point to an impact from that on transmission. So we continue to look at all those data, and as I've said before, and I think the governor said, we're watching these community transmission trends real closely. We know that there's a lot of effort going on in the hospitality industry to make sure that not only proprietors are fully informed of what the requirements are and the potential consequences of not complying, but how very important it is that patrons understand that as well. So the big push has been on education and communication. Most of the enforcement efforts have been pretty successful in making behavior change. But as the governor has said, we need to keep all options on the table as we see where this goes over the next couple of weeks.
Thank you.
Operator, we have time for one more question.
All right. Our last question will come from the line of Darren Everson with KTOE Radio. Your line is open. Please go ahead.
Thank you. Looking at the data of deaths, number of deaths, since today is the last day in July, I noticed only one day in July that there were double-digit deaths in the state of Minnesota. That's a good thing, right? And basically, what do you credit the lowering death totals to as we see some increased cases, increased testing, everything like that? What are you crediting that lowering death total to?
Well, we certainly are grateful to see that mortality data improving. And we think it's due to a number of things, and certainly Chris can chime in here as well, but we've talked before about the systematic improvements that have been made in the long-term care sector on increasing prevention activities and increasing protocols to really dial in on rapid identification and rapid control of spread in those environments. We think that's been very helpful. We also have heard a little bit from Dr. Joan Hick and Dr. Ruth Linfield on prior calls, and I think Dr. Shacker mentioned this as well, that clinical care has improved, that the treating physicians have learned more about best protocols, earlier intervention with oxygen therapy. And in fact, if Dr. Shacker's still on the line, I'd invite him to comment as well, just on sort of the clinical improvement front. But before turning it to see if Dr. Shacker's still on the line, Chris, do you have anything else you'd want to add sort of from a data perspective?
Sure. Everything that the commissioner just said related to the improvements in long-term care are right on, and we're really pleased to see reduction in deaths. But one thing that I do want to mention is that mortality and the deaths is a lagging indicator. So just as I mentioned earlier about that stone in the pond and the ripple effects, ultimately we are going to see the ripple effects of all these cases in younger ages. So while those groups for themselves are not at as high a risk for severe complications, the fact that there are cases means that other people will see cases in others that they have been around and exposed to, and will continue to see more cases, and ultimately our deaths will go up as a result. And we mentioned on an earlier call the concern that we have that we're seeing more cases in staff in long-term care, meaning that they're getting exposed outside of the facility and then unwittingly bringing it in. And so we want to make sure that people are aware that they need to think about all the roles they play, not just their age and their own particular perceived risk, but the role that they play via their job and other interactions. And with that, I'll turn it over to our guest.
Yep. Dr. Shacker, are you still on the line?
I am. The question of not seeing as many deaths as we've seen before, and the comment about changing clinical care, I can give you a really good example of that. At our hospital, we have multiple clinical trials that are open, each of them looking at a different approach for the treatment of COVID. And one of the things that we're having to do is that we're having to change the protocols quickly because the standard of care changes so fast. So when we started, we didn't have remdesivir. Now remdesivir is part of the standard of care if it's available. Dexamethasone, steroid, has been shown to reduce mortality and improve clinical outcomes, and that's become a standard of care. And so, when we have a protocol, we have to go back and amend the protocol. And so it's just, that's how fast things are changing and how fast things are improving. It's remarkable.
Thank you.
Thank you to everyone on the call today. That's all the time we have this afternoon. If you had a question we were not able to address, please feel free to reach out to our communications office this afternoon. Have a good day, and we will be back with you again on Monday.
This has been a WDIO News Special Report.